Hello, everyone. It's Alessandro Sticchi from University of Bern on behalf of PCR Online. It's a great pleasure and honor today to have here Professor Rebecca Hahn. Dr. Hahn is a professor of medicine at Columbia University Irving Medical Center, Chief Scientific Officer of the EchoCore Lab of the CRF, and the Director of the Interventional Echocardiography at the Columbia Structural Heart and Valve Center. She's one of the most active members of the American Society of Echocardiography, American College of Cardiology, and Academic Research Consortium Committee, and of PCR Tricuspid Focus Group. And so we have the great pleasure today to talk with her about the state of the art, about transcatheter therapies for tricuspid valve disease, recently published on EuroIntervention. Professor Hahn, a warm welcome on behalf of PCR Online or the PCR Companions family. Thank you very much for being here today with us.
Oh, it's my truly great pleasure to participate in this interview. I couldn't have been more excited about the publication of the manuscript, which took a lot of work from the TR focus group, and I think resulted in a really important manuscript that will withstand the test of time.
Absolutely, absolutely. We have some questions. We saw that the manuscript started with the anatomy classification proposal previously published by you on JACC Cardiovascular Imaging in July. So why is the tricuspid valve the only valve with a new classification proposal, and why it's so important to start from here?
Well, thanks for that question. I think what we've all learned in structural heart is that understanding anatomy becomes very, very important for being able to determine treatment. And so we've known from autopsy studies for decades now that the tricuspid valve is very unusual in that its anatomy is extraordinarily variable. And so these autopsy studies were intriguing to read. You know, you have 3, 4, 5 leaflets or various indentations of the leaflets. And what we discovered early on in looking at the tricuspid valve is that we could actually see those different leaflets. We could see the indentations, we could see the clefts. And so with our experience with the transcatheter edge-to-edge repair device, knowing where those clefts are became so important. And so we then got a group together, 2 sites from Europe, 2 sites from the United States, all with experience in transcatheter edge-to-edge repair, because I think that particular device becomes most important to know about morphology. And then determined the prevalence of each of the different types that we saw. And what was really great to see was that all the sites had roughly the same incidence of each of the different types. And so really confirming the existence of a bicuspid tricuspid, or a 4-leaflet or 5-leaflet tricuspid valve. And I think even since the publication, there have been already 2 manuscripts out there that have looked at technical success of the TEER device based on morphology, and have found that indeed greater than 3 leaflet morphologies become a challenge sometimes to reduce the amount of tricuspid regurg.
Totally, it is absolutely important, essential to understand, and then to bring in practice the anatomy with the treatment. The second paragraph of the state of the art is related to the classification of tricuspid regurgitation. What is new in the proposed integrated classification of the secondary TR?
I think this really is one of the most important contributions of this manuscript. It's a brand new classification, because the simplistic classification of primary and secondary disease just doesn't describe all the different morphologies that we end up seeing. We now know that the tricuspid valve is not just about the leaflets. And so when you divide it into primary and secondary disease, you're just thinking about the leaflets. Is it primarily involving the leaflets, or is it not involving the leaflets? But in fact, when you look a little deeper at the functional disease, we have a whole variety of primary pathologies that can contribute to secondary disease. And those are related to different morphologic constructs of the leaflets, the atria, and the ventricle. And so this new classification is just, it's super important, I think, because we also know that when you divide functional into atrial functional and ventricular functional, so atrial functional is more about the annulus and right atrium, and therefore the leaflets look normal. They close roughly at the annular plane, but there's just too much annulus, and so you can't cover the annulus with the leaflets, versus ventricular functional, where now you have displacement of the papillary muscles in the setting of right ventricular dilatation and dysfunction. And that therefore tethers up the leaflets. And now the leaflets close toward the apical plane, apical to the annular plane, and therefore don't have enough leaflet length to cover the orifice. And so dividing those two are important because we know outcomes are different based on the two, and device choice may be different depending on which morphology you have. So the division of secondary into atrial functional, ventricular functional, very important for tricuspid valve. And then the one other category that is now its own category, which I think is completely justified, is the pacemaker or cardiac implantable electronic device, CIED, related tricuspid regurgitation, because now you have a leaflet or even a subvalvular problem but there's a lead in there. And so it can actually be primary because you have a device in there. And it's not really secondary to any physiologic problem, for instance, on the left side or in the pulmonary circulation, but it's secondary to an implantable lead. So that being a separate category, also very important, because we're now seeing about 20% of our patients coming into clinic with pacer-induced tricuspid regurgitation.
Yeah, exactly. And TR is continue to be an underestimated disease, and the definition of severity remains challenging.
Very challenging.
What advice can we share with the clinical cardiologist to recognize the disease severity via using the transthoracic echocardiography as a first level before a multimodality imaging approach?
That is such a great question. I think the most important thing that we've learned is that we have been underestimating tricuspid regurgitation based on the usual criteria that we've used. So in the past, I think we've relied on looking at the tricuspid valve severity by color Doppler jet area and roughly using the same criteria as mitral regurgitation. But the problem here is that this is a very low pressure side, and therefore, because color Doppler jet area is dependent on momentum, you could have a very large orifice with a much smaller jet area. And so consequently, if you're going to use the same jet area visual quantification as you do on the mitral side, you're underestimating how bad it is. We've been doing this now for decades, unfortunately. And I think the main thing to learn is that don't rely on color Doppler jet area. Instead, I think what's more important is to look at surrogates for the size of the hole. So if that surrogate would typically be vena contracta diameter or width. But we also know that the tricuspid valve is really complex, as we discussed already, and that the orifice is not a circle. Therefore, it's super important for us to now look at two orthogonal planes and average those vena contracta. And if you get an average vena contracta of 9 or a single vena contracta of 7, but from an apical 4-chamber view, then you probably have severe, and those patients really should be referred on to a heart valve center of excellence, a place that's used to quantifying and using 3-dimensional echo to quantify, or quantitative Doppler. Those would be all important messages for the clinicians, that we've been underestimating TR, that we're allowing the patients to not be brought forward for therapy too long. Even for surgical therapy, we know that we're waiting too long. And to bring those patients forward to valve centers early in their disease process.
Yeah, absolutely, totally. And that's why this state of the art is so important for the community. As you say, the tricuspid disease is not only the disease of the valve, but of all the right heart. So the right ventricular function, the right ventricular assessment is another essential parameter in the evaluation of patients with tricuspid disease. The ratio between TAPSE and SPAP currently is the most trustable value for determining the tricuspid valve function. Could we hypothesize to extend this ratio, this evaluation, to other intervention in the transcatheter field?
That's a great question. So, I mean, I'm going to back up a little bit to talk about RV function in general. I think that we have many different measures, non-invasive measures, mainly relying on echo in the past for assessing RV size and function. But as you've already implied, the right ventricle is very sensitive to afterload. And therefore, this index that you're talking about, the TAPSE, which is tricuspid annular plane systolic excursion, which is a measure of longitudinal shortening, and dividing that by the pulmonary artery pressure, or the estimate of pulmonary artery pressure, gets at the concept of RV-PA coupling. And so the function of the RV, which is BTAPSE, is now indexed to a measure of afterload, which would be pulmonary artery systolic pressure. And so that RV-PA coupling means that RV function will continue to increase as pulmonary artery pressures increase, because they're coupled, and so it's able to compensate. When it becomes uncoupled, and now the RV cannot compensate for the increase in afterload, and that index of TAPSE over PSP starts to fall, then we believe that the RV is now over on the other side of the Starling curve and is now failing. And so that, as you implied, is a really important measure that we've already looked at a number of different disease processes: aortic stenosis, just heart failure, pulmonary hypertension, all of these other pathophysiologic constructs have looked at RV-PA coupling as another measure of outcomes. And so it turns out that we now have at least a couple papers out there looking at RV-PA coupling. And we can use other measures, by the way. It doesn't have to be TAPSE. It could be RVEF. It could be RV strain. It could be S prime on the tissue Doppler, and other measures of pulmonary afterload. So it could be PVR. So anyway, combining that into an index has now been looked at in tricuspid regurgitation. And as you implied, it looks like there are outcomes strongly associated with being uncoupled. So an RV TAPSE over PASP of under 0.31 millimeters per millimeters of mercury suggests poor outcomes in patients. And we've also just published out of the TriValve registry this same index, finding again that coupling and uncoupling will determine outcomes. But another really interesting finding, which is that after the valve is intervened upon, and most of those patients in the TriValve registry had the TEER device, that a drop in RV-PA coupling numbers actually predicted better outcomes. So what I think that means is that the patient has to have some RV reserve and has to actually be a little bit hyperdynamic in the setting of unloading from the tricuspid regurgitation. And that even though we uncover mechanical dysfunction once we put the devices in, there's enough reserve that those patients will continue to do well. So I think we're really learning a lot about RV-PA coupling, but I agree with you that it's going to become an important measure for all of us on the tricuspid side.
Wow, that's fantastic. That's really really exciting, and this is also very, very important for the device selection. And device selection is one of the most hot topic in the field, and the preprocedural CT is now mandatory besides the 3D transesophageal echo. What is your perspective about patient eligibility in tricuspid intervention, repair, replacement in the future? What are the possible solutions?
Well, I mean, I think there's so many devices out there now. The tricuspid field is just packed, much more so than the mitral side and obviously the aortic side. And the reason for that is because of the variability, as we discussed, of the morphologies, and the fact that we will have to have multiple devices available to us to treat all these different morphologies. So I think that in the future, everything is possible, that we're going to need repair devices that involve the leaflets and the annulus, and that the replacement devices, which have already shown great efficacy, these are devices that take away all the tricuspid regurgitation, but still may have some pitfalls associated with it. So remember, we're talking about, eventually we will be able to talk about, on the tricuspid side, lifetime management. We don't do that now because we're treating all the end stage patients, but eventually we will want to know about durability. And lifetime management, as in, are we able to put in second devices after we've put in a first device? So that all the devices will have to deal with those types of issues eventually. But I think one of the biggest pitfalls currently is imaging, intraprocedurally. And so being able to get technical excellence on these devices, since the leaflet devices depend so much on being able to see these extraordinarily thin leaflets, and the annular devices depend on being able to implant multiple anchors in an annulus that has no fibrous tissue. So the imaging aspect, which has tended to favor replacement devices, which don't require as intense imaging to place the device correctly, I think will be eliminated with the development of 3D ICE. And so the 3D ICE catheters that are now available, and we've been looking at one of the phased array 3D ICE probes, which is just a phenomenal advancement, I think will change that algorithm and level the playing field as far as intraprocedural imaging, and then really make possible a patient-specific device choice in the future.
That's fantastic. Really, really an exciting field.
Yeah.
Professor Hahn, thank you really much. Natural thank you, natural thanks from all the PCR online, from the PCR families. Thank you very much for being with us today. And please stay safe in this complex period.
Thank you so much.
Bye.